Welcome to Lessons from the Lab. We're going to be talking about blockage today, and we're going to be specifically focusing on brain blockage, which is also known as a stroke. There's two types of strokes that we have. There's hemorrhagic, which is actually a bleeding out blockage, or bleeding out, but then it causes leakage, and so blood flow is still not getting to those surrounding tissues. Or there's ischemic stroke, where a blockage is literally pushed from the heart up to the brain, causing that block in blood flow. And if you remember that all of our treatments and all of our ideas when it comes to any type of blockage in the body is to restore the flow. So all of our interventions, all of our thoughts are based on how do we restore the flow through that blockage. And it's either we open it or we reroute it. So hypertension is probably the most common cause for hemorrhagic stroke, which is that bleeding, right? That high blood pressure pumping in causes a rupture, and then they have a bleeding in the brain. So that's something that we always want to pay attention to, is that's why we worry when we see people have high blood pressure. The other thing, though, is for ischemic stroke, though, is AFib, atrial fibrillation. So how does something in the heart cause an issue in the brain? Well, I've got some models here that I want to use to demonstrate. So I've got some balloons and I filled them with Jello, and so you can see that clot that's in there. And I have another one, just so you know that I'm not trying to pull a fast one on you, that I got another one that's got Jello in it, all right? And we're going to have two hearts, and we're going to have one heart that is beating nicely, right? And if it's my heart, it's probably beating, 100 times a minute right now because I'm nervous. But if it's this one, it's an AFib heart. So it's just quivering, right? Because those top two atria are quivering. And so what's going on is when that heart is beating, it's breaking up all those clots. And it's breaking up that blood and it's pumping it through, so there's nothing settling. Because anytime blood settles, it just stays and it starts to get clotted up. That's what platelets do, right? Is they purposely cause that in order to help us from stopping bleeding. But that AFib heart is it's still just quivering. It's not pumping. So what we've got to kind of help pull down this point is I've got my daughter here, and she's been pumping her heart for a while, okay? And so we're gonna end up cutting open this heart so that we can see what it looks like when a heart has been beating nicely for a while, right? This has been solid Jello that you've seen, and now we have nice loose blood that's been pumping through the body and that's doing its job. But when we have an AFib heart, a heart that has just been quivering, okay, thank you, Rhett. Next plate. Okay, grab our little AFib heart here, and we're going to cut that one open, and you're going to see, let's do it this way so when it bleeds I can show it to him. Do it just like you did. Hold that. Hold that. There you go. Ready? When we do our AFib heart, okay, we've got those clots that are coming, and they are going to cause us all sorts of problems when we do eventually get one really good beat and it goes up into the brain, all right? And that's going to cause a lot of problems. So what are kind of treatments that we have for AFib? Ew, I'm sticky and gross. So what do we have? I think it got my neck too. But what do we have for treatments, right? A lot of our treatments are, one, to keep the heart beating a good, normal rhythm. But the other one is all those anticoagulants that we give. It's preventing that stroke. And so that's what's really important about the pathophysiology. Let's dig a little deeper into what's going on in the brain once it's not getting that blood flow. So we talked about, like, that clot gets thrown up there, and now we don't have adequate blood flow going to the rest of the areas of the brain. So you're going to start seeing swelling and pressure as that tissue starts to die, because that tissue will die. Tissue does not like not having blood flow, oxygen, nutrition, all of that stuff going to it, so it'll start to die. And then we have problems. All right, and there's swelling that starts to happen, and there's a certain amount of time that happens, and we can see that on a CT scan, right? Because we can't really see things that aren't hard and fast in CT scans, but we can see the swelling that's starting to happen. We can see the changes in the color from the difference between a hemorrhagic stroke and an ischemic stroke, and how that changes in the colors of the CT, or the density of the CT scan. kind of an interesting thing about the brain is we have two hemispheres to the brain. So if our stroke is on, we're going to say that our stroke is on the left side of the brain, that means the right side of our body is what's going to be affected. That's where we're going to see those symptoms, all right? And we're going to see the weakness, the arm not be able to lift up, whatever it is of those symptoms that you're going to see. Depending on the area of the brain also depends on what symptoms you see, all right? Frontal lobes, you're going to see more impulsiveness, you're going to see, we have a lot of speech issues. Back of the lobes, we're going to have more vision issues and that kind of stuff. So there's a lot more, it depends on the area of the brain that has the stroke as well, as where that clot gets lodged. The other interesting thing about hemorrhagic stroke is we've talked about that it's bleeding. It's bleeding into the brain. When people have hemorrhagic strokes, one, the survivability of a hemorrhagic stroke is significantly less than an ischemic stroke because it's not like you can go in and put pressure on that bleeding area. So we can't fix a lot of times those issues that happen. We just have to let the body kind of fix itself. And then if you think about somebody who maybe was on some sort of anticoagulant for something else and they were then got a hemorrhagic stroke, now we've really got a bleeding issue that's going on. But the other thing with the hemorrhagic stroke is something you're going to see is what we call WHOL, worst headache of their life. Worst headache of my life. They'll come in and they'll say, I have the worst headache of my life. I don't know what's going on. I feel so awful. And it ends up being a hemorrhagic stroke because the body is kind of funny. It doesn't like blood outside of areas where that blood is supposed to be. And so that blood actually starts kind of burning that tissue because that tissue just isn't used to having blood on the outside of it. So that's kind of the difference between an ischemic stroke, which is a blockage primarily from a fib, okay, the clotty, gelatinous stuff getting stagnant in the heart, and then all of a sudden a good pump happens and it goes up and causes problems. That's usually your ischemic stroke. But your hemorrhagic stroke's usually from hypertension, and that's going to usually be the reason we really want to keep people's blood pressures under control and down into a certain area because we don't want them to blow a vessel. A lot of times they also come from, you'll hear people say AVMs, okay? It's arteriovenous malformation. And that means they have an area where the artery and the venous system kind of got connected. You have to think the brain's a pretty big intertwined area of vessels. And so there could be two vessels that have kind of grown together. And when they get a big push, they can have some problems there. So those are kind of the two big things that come from stroke. The next thing that we're going to cover is how we're going to assess a patient when they have one of these issues going on. All right, so we covered the patho of how the strokes are different between ischemic and hemorrhagic, but that's honestly not going to matter a whole heck of a lot if you're out in the field. You don't really care if it's a hemorrhagic or an ischemic. We just know that we're in trouble, and that's when we have to start getting into the assessment of a stroke. And we have to go through and figure out what is it that we're trying to assess. And what we want to assess is what we call the FAST, is an easy way to remember it. We've got our face, our arm, speech, or smile, and time. All right? Face is all of a sudden they have a facial droop. So we've got someone who's having issues and all of a sudden they have a facial droop and they have something going on and we have to figure out what's going on. All right? The other thing is their arm. So all of a sudden their arm is drooping. All of a sudden they are having some issues in that arm and it's falling, or they can't hold their beer can anymore. You're at the family picnic and all of a sudden they can't hold that beer can and they keep dropping it and you can't figure out what's going on. Or somebody who's writing and all of a sudden they can't. Speech, all of a sudden they're getting words mixed up. They keep saying truck, 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 or they keep doing word salad, and so all of a sudden they're like spreading off different words that's nonsensical, and it doesn't. You're like, what's going on? And you keep asking them questions, and they still can't answer. Or you might ask them to smile, and they kind of have a droop on their smile, and they can't quite smile right. And you're like, whoa, something's going on. Time is two different things. It's the time of last known well, okay, and the time to call 911. This is really important. Last known well. This is really, really important for us to know when's the last time they were well. Because if someone, say, went to bed at 10 o'clock at night and you talked to your mom last night at 10 o'clock at night and she was fine, and then you wake up at 6 in the morning and you're like, ooh, I just saw something on a show, I need to call her, and she's not, you can't answer the phone or can't talk right or something, her last known well time was 10 o'clock at night, okay? So that gets really important because there's medications that we're going to give when we talk about treatments and what we're going to do in the emergency room. If that time is a certain amount, we can't fix anything. So we then just have to treat the symptoms and maintain as best we can. But the treatments change based on the time of last known well. So that becomes really important. It's also really important to call 911. I know if you're at the family picnic, it's easier for you to scoop them up and just take them to the ER. The problem with that is the ER doesn't know they're coming. And in order to keep people safe and to keep people getting the care they need, right? Because as soon as they come in that door for the ER, they're going to start treatments. So it's really important that we call ahead. We call 911 so they can say, I have a patient with a stroke or stroke symptoms, because what's going to happen is they're going to clear out the CT scanner. They're going to clear out the lab and get someone there right away for lab. The staff is going to be ready and prepared for them. So it's really important that if we know that that stroke is coming in, we can get ourselves ready. So I know families just want to scoop and run, but it's really important, even if they scoop and run, to at least call 911 and say, hey, I'm heading to this hospital and we will be there in about 5 minutes. So they can then at least report on to that place that they have one coming. So they can prepare for it, because the doctor may be up on the floor doing rounds. They need to be down in the ER so they can be helping and be ready for what's coming in. So it's really helpful if we call 911. So when you're talking to families, when you're doing education, you make sure that you say, call 911. Don't just scoop and run. Make sure we're getting help there. And then the paramedics, they can be putting in IVs and all sorts of other treatments as soon as they're coming into when they come into the ER, they're ready to go, instead of having to almost be behind and now starting IVs on them and getting that stuff ready, so that we already have that stuff going. So face, arm, speech or smile, and then time of last known well, and time to call 911. Those are kind of our rapid symptoms. Now remember, with a stroke, it's unilateral. Typically, I mean, you say that and then you come up with one that isn't, but it's usually unilateral, meaning one side's affected and the other isn't. And so you may see all of a sudden that they slump or they can't do something. So there's going to be some changes, all right? I know people like to always look at their pupils. Movies like to show looking at pupils. Pupils are significantly the last things to respond to the brain having problems. So usually you're going to see some of these issues first. Another one you could see is level of consciousness change, where they're not awake and they were. Sometimes you might see that more with like a hemorrhagic stroke or an epidural bleed. Those are kinds of things you might see where that level of consciousness more changes. A lot of times with strokes, though, they're awake and they just can't do things that you want them to do. And something else you always want to assess for is our airway, all right? Because they may not be able to take care of their airway at that point in time. If they've lost so much issue, they might be having an airway concern. So you always want to make sure that you're focusing on some of the big bad ones. But when we're teaching families, these are predominantly some things that we're going to teach them and that we're going to see. And remember, call 911. Get that help coming to you so that the help is ready to go and the timeline isn't messed up. The next thing we're going to talk about is what happens when they do go to an emergency. All right, we've talked about the patho, we've talked about different assessments. Now we're going to talk about what happens when we actually get to that ER. And this is really important because time is brain. And so we want to make sure that we are using our time effectively. All right, so what we're going to do, the first thing we're going to do for somebody that we think is coming in with a stroke is we need to get them to the CT scan. The reason we need to get them to the CT scan is because we need to know what kind of stroke this is. And an ischemic stroke and a hemorrhagic stroke are going to look different visually on a CT scan. So it's really important that we get that time is brain, and that we got to get them into that CT scanner. So that's why it's really important to call ahead so we can get them into the CT. The drug we're going to use is TPA, Altepace. This is a medication that we'll use, and it's Drano for the Braino is what a friend told me one time, and that stuck in my head, so that's what I call it. This is Drano for the Braino, right? Just like your clogged drains, we want to get them unclogged and cleaned out. So we're going to give TPA. The thing with TPA is you can only do it for 4.5 hours. 4.5 hours from onset time. So that's why we have to go back to that last known well time. It's really important for that TPA, 4.5 hours, that's a really short window, but it has some amazing effects. TPA is going to clean out that clot. Now, what if we're having a hemorrhagic stroke? Can we give TPA? No. If we give TPA to a hemorrhagic stroke, we've just made them bleed more. In fact, if we go outside of this 4.5 hours, we can cause an ischemic stroke to become a hemorrhagic stroke, because all those blood vessels, remember, they're all dying in here. All those blood vessels and all that tissue is dying, so those vessels become very friable, and so they then will rupture if we can give TPA. They all of a sudden start leaking blood. So you can take an ischemic stroke and make it a hemorrhagic stroke by giving TPA outside of that 4.5 hour window. Now there's some facilities and some practitioners that can go in and do it at about a 6 hour mark, but for our purposes, 4.5 hours is the mark that all the research is right now, and we're just going to stick with that because that's what I've been told about as far as nurses go. That 4.5 hour window is what we know that we can go. Anything outside of that, that's going to be a physician-based decision and not something that we're going to decide on. But it makes us understand why it's so important that we recognize it quickly, we get them to where we need to be so that we can deal with this. So those are kind of the things in the ER. They're also going to be doing neuro assessments every hour, every 15 minutes, that kind of stuff, to see the changes, all right, and see if we can get this vessel open. Because remember, our goal for any blockage is to restore flow. We want to restore flow, and if the best way to restore flow is to open it, but sometimes we have to reroute it. In the brain, we don't get the luxury of rerouting. We have to get it open, or that damage then becomes permanent. So let's think about when we're going to the ER, when we see somebody that's having some of these issues, that we're calling 911, we're getting to the ER, because that time is brain. And we're going to have those deficits become permanent if we don't get that medication in. All right, so we have now talked about the patho, hemorrhagic versus ischemic. We've talked about assessment, basic fast assessment, but also those extra steps that nurses have to be aware of. And we've talked about why it's important to get them to the place where they need help. The other thing that we have to understand as nurses is rehab. Okay? We want to get them to rehab. We want to get them through this incident, and we want to get them to rehab so that we can restore whatever deficits they may have. Some deficits may be permanent. I think it takes about a year to kind of know what your new normal is. And so it takes time to figure out and let them regain some of those muscles back, regain some of those neuro connections. You might have to work with different groups. So think about the different groups that are in rehab. We have speech therapy, who will help them learn to re-talk, help them learn with swallow again, because we get a frequent amount of time where people lose some of their swallowing ability. And that can be a challenge. We have occupational therapy, or OT. They'll help them learn how to put on their socks, how to work in their home. And that becomes really important for them returning home, because we don't want people to be in facilities. Strokes cause a lot of damage and cost a lot, because so many times the damage is permanent. And if you take somebody who used to be a truck driver and used to be supporting their family and just fine, and now you've got someone who has left-sided numbness and paralysis of that left hand, well, they can't really be a truck driver anymore, or a mechanic, or a nurse. I mean, there's just a lot of struggles that happen when you are working with that population. They can't necessarily go back to what they used to do. Hopefully, with time and with practice and with therapies, they can go back. We also have physical therapies. So people learning to re-walk, learning how to get up and down, learning how to go up and down stairs. These are all different therapy teams that are going to have to work with them. I want you to think about some of the interventions that we have for some of our stroke patients. What if they can't swallow? What kind of interventions do we have for those patients? Think of aspiration precautions. What are those kinds of things? Other things that we have to do is think about safety mechanisms for patients. What if they can't walk anymore? What kind of safety things are we going to have? So what I'm going to do is I'm going to post a picture for you here, and I want you to look at this person, and I want you to tell me what kinds of treatments do you think for her? What kind of interventions are you thinking that she's going to need for you or for herself to be able to be successful or be able to go home? So just by doing kind of a little doorway / just look assessment on this woman, think about what side do you think her stroke was on versus what side is affected. I also want you to think about what kinds of interventions are we going to have to put on for her. So that's kind of all I have for stroke right now. But just remember that with stroke, ischemic strokes are the most common ones. They're also the most common ones for us to be able to save and to fix people from, because it's about that clot and reopening that clot. When it comes to a hemorrhagic stroke, those are just so much more dangerous because that bleeding, again, you can't really put pressure on somebody's bleeding. So I hope you had fun with this video. I hope it helps you pull together some of the ideas of how blockage affects the brain. And please let me know if you have any questions.